Now that we know how things are flowing through the heart, it's important to connect this to circulation as a whole and regulating blood flow. So our capillaries fluid move through membranes governed by Starling forces, which includes capillary hydrostatic pressure that pushes fluid out of a vessel, interstitial hydrostatic pressure that pushes fluid into a vessel, plasma oncotic pressure that pulls fluid into a vessel to balance protein concentration, and interstitial fluid oncotic pressure that pulls fluid out of a vessel. And we can relate these different blood flow kind of components of a capillary all the way back to some of our larger picture discussions in blood pressure and cardiac output. As a reminder, the kind of fundamental question when it comes to blood pressure is mean arterial pressure equals cardiac output times systemic vascular resistance. It also can equal diastolic BP plus 1/3 of systolic minus diastolic BP. Cardiac output is heart rate times stroke volume and typically is 5 liters at rest. Stroke volume is determined by preload, which is our ventricular filling volume or end diastolic volume. Frank Starling governs that mechanism. Afterload, which is the resistance of the ventricle that it has to overcome to eject blood or the pressure in the aorta. And contractility, the intrinsic strength of the heart muscle itself, which is influenced by our sympathetic nervous system and calcium. The resistance then in the vascular system, our systemic vascular resistance, is determined by diameter of arteriolars or our arterioles. These are our resistance vessels right before capillaries. And this is where we have this relationship with Poisson's law, where resistance is 1/4 or 1 over radius to the 4, I should say. This means that a tiny little itty bitty change in radius has a massive effect on resistance. Therefore, vasodilation, vasoconstriction govern this process. If you are vasodilated as a vessel, you'll have decreased systemic vascular resistance, therefore decreased mean arterial pressure. If you're vasoconstricted, you'll have an increase in systemic vascular resistance and an increase in mean arterial pressure. The body can auto-regulate this process, and the tissues can maintain a constant blood flow despite changes in perfusion pressure. We really see this in the brain, the kidneys, and the heart, the places that need blood consistently the most. Metabolically, we have some autoregulation when our tissue has increased metabolic needs. There'll be an accumulation of metabolic vasodilators like carbon dioxide, hydrogen ions, potassium ions, adenosine, lactic acid, and decreased oxygen, which leads to local arteriolar dilation to increase blood flow to match the metabolic need. This is how we have more blood going to our active muscles during exercise. Myogenic autoregulation is when we see an increase in transmural pressure, our smooth muscle stretches, and that leads to a reciprocal contraction or the Bayliss effect. This prevents capillaries from getting overperfused when arterial pressure rises. And endothelial factors, things from the endothelium like nitric oxide, which is a very potent vasodilator. It's released by endothelial cells when shear stress occurs, essentially when blood vessel or blood cells are dragging against the endothelium. Endothelium 1 is the opposite, it's a vasoconstrictor. And prostacyclin PG2 is a vasodilator and a platelet inhibitor. If we step out of local control, neuroregulation is mainly through our baroreceptor reflex. Baroreceptors are sensitive to stretch, and they're mechanoreceptors. They're located in the carotid sinus and the aortic arch. If we have increased blood pressure, it will increase baroreceptor firing, more action potentials, which will be sent up to the nucleus tractus solitarius in the medulla oblongata of our brainstem. That increases parasympathetic output, which will decrease heart rate, and it'll also decrease sympathetic output, which will encourage vasodilation. The net effect is blood pressure returning back to normal, and so this is a rapid short-term control mechanism. Sympathetic fibers, on the other hand, release norepinephrine, which act on alpha-1 receptors that are located on vascular smooth muscle, and that leads to vasoconstriction. And this is the main mechanism to redistribute blood flow during exercise and stress states. Looking at hormones, the ROS, the renin-angiotensin-aldosterone system, We can see if there's decreased perfusion to the kidney, decreased blood flow to the kidney, renin's released from the kidney. It stimulates angiotensin 2 to be active by converting angiotensinogen from the liver to angiotensin 1. Then angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme from the lungs. Angiotensin 2, the active component in this process, causes vasoconstriction and aldosterone release, which leads to sodium and water retention. Therefore, blood volume and pressure rise. Antidiuretic hormone or vasopressin is released from our posterior pituitary. It happens when there's low blood volume, and that leads to vasoconstriction and water reabsorption, so increased blood volume. Atrial natriuretic peptide released from atria that gets stretched due to too much blood volume, too much preload. It will lead to vasodilation and natriuresis, so getting rid of sodium and water via the kidneys, which lowers blood pressure. And epinephrine or adrenaline binds to beta 2 mediated vasodilation in skeletal muscle and alpha 1 mediated vasoconstriction in the skin and the gut, essentially helping us run away from danger, but not do processes like digestion, absorption, or non kind of urgent processes in the body. This is looking at ROS regulation, kind of where these processes start from. Looking at the whole system if you need kind of a visual to remind yourself of what the system looks like. There are a few forces that drive lymph flow that's important to note here. Our intrinsic lymphatic pump, which is the smooth muscle in our lymphatic vessel walls, does contract rhythmically. There's also valves that prevent backflow. Skeletal muscle pump, the contraction of surrounding muscles will compress lymph vessels, propelling lymph forward. Our respiratory pump does create kind of a negative inner thoracic pressure, which draws lymph up towards the thoracic duct. Arterial pulsations, also kind of like the skeletal muscle pump, will compress nearby lymphatics and move fluid up. And increased interstitial pressure during inflammation just pushes more fluid into the lymphatic system. Fluid, like we mentioned, is filtered out of capillaries governed by Starling forces. And then this fluid that's not reabsorbed enters into our lymphatic capillaries. Typically, around 3 liters per day is returned in this way. And the rate of lymph formation is really the driver of lymph flow rate because if more fluid filters out of capillaries, more will enter into lymphatics. Our sympathetic nervous system can increase the rhythmical contractions of our collecting lymphatics, which increases flow, and exercise will increase lymph flow because of our skeletal muscle pumps.